So first, what we know is that providing end-of-life care in the ICU is very common. So approximately 1 in 5 people in the United States who die receive ICU care at or near the time of death. So that translates to a little bit over 500,000 individuals each year who receive end-of-life care in the ICU. The second thing we know that's important about end-of-life care is that there are some gaps in the quality of the care that's delivered. So from single-site and regional prior studies, they've shown us that there's important gaps in things like symptom control or communicating with patients and families near the end of life. But what we don't know is whether those findings generalize across the United States and whether there's variation in between each unit providing that kind of end-of-life care. So we took advantage of a large 68 hospital quality improvement collaborative. It was known as the ICU Liberation Collaborative. And so this was sponsored by the Society of Critical Care Medicine and the Gordon and Betty Moore Foundation. And actually the primary goal of the collaborative was to promote management of pain, agitation, and delirium in general in the ICU. So it was not specific to end-of-life care. But we used the structure of this large collaborative to conduct an additional observational study looking at the care specifically delivered to those patients who died in the ICU. So we identified several major gaps in the quality of end-of-life care when we looked at the entire collaborative at large. So for example, we found that we found that only 40% of patients had an advance directive documented at any point in time during their hospital stay in which they died. We also found that some of the unit level features of ICU care failed to support high quality care. So for example, only 1 in 3 ICUs had a regular or structured opportunity for ICU clinicians to reflect on providing care for dying patients. And we identified several other major gaps. So in total, our study was able to paint a broad picture of the current state of end-of-life care delivery across the United States. I think importantly, we also found that there was wide variability in the end-of-life events, so things that happen to patients in the time frame immediately preceding death. So, for example, patients, the median rate of the receipt of CPR at the end of life was 11%, but the unit level range varied from 0% to almost 50%, so a wide range in variability. And what we found, prior studies have also shown this level of variation in the delivery of life-sustaining treatments. But what we've also added to the literature is demonstrating a wide variation in the control of pain and delirium at the end of life. So we found that the median rate of significant pain in the last day of life was about 25%, but there was an extreme range for that measurement, so from 0 to almost 100% based on the units. And similarly, we provided one of the first large descriptions of end-of-life delirium. And we found that the rate overall, the median rate was 40%, but again, a very striking range from 0 to almost 100% based on which unit you were admitted to at the end of life. So I think what our study provides after establishing this broad picture of end-of-life care across the United States are opportunities to target interventions to improve ICU care. So for example, we can learn from the highest performing units about how they are supporting high quality end-of-life care and disseminate that information to ICUs across the United States, ultimately to try and ensure that every patient who dies in the ICU receives the highest possible quality of care. I think our findings also suggest that where we need to go moving forward is to develop a better understanding of the drivers and the mechanisms of this variation in end-of-life care. So why is one unit so different than the next in terms of accomplishing high quality end-of-life care for our patients. So I think to build on that, what we need to have a better understanding of is what are the characteristics or the structures within a particular ICU that allow the clinicians to provide high quality care. So to understand the determinants and the mechanisms that a very high performing unit has developed, so that we can then translate those mechanisms from what we've established, are some high performing units, and can translate that to other units across the United States and develop clear interventions that we think have a high probability of improving care for everybody.